All right, guys, welcome back to another episode of Livewire. I am your host, Jared Moore, and Livewire is the show where we take your questions from the chat. On today's program, we are going to be speaking with Grace Fox from the Tribal Health. She is a Tribal Healthcare Policy Analyst at the Native Nations Center for Tribal Policy Research and also a Seminole citizen. Thanks so much for joining us today, Grace.
Yeah, thank you so much for having me. I'm really excited to be here today.
Today we're going to be talking about a report that the Native Nations Center recently published about purchased referred care and cancer. And I've given you guys a link to that in the description of this video. I highly recommend you go and read it because not only is it going to give you some information about the problems with getting cancer care for IHS patients, but it also explains the process for purchased referred care really well and gives kind of like a little bit of a history of it. So if you're a tribal citizen and you're ever going to have to go get health care at a place that's not in the IHS clinic, right, you have to go through this process, and it's good to know what it entails before you have to do it because it can be kind of convoluted and confusing and cause problems. But with that being said, Grace, I wanted to say thank you for coming on again. And then could you tell us, before we get into the report, could you tell us a little bit about the Native Nations Center at OU and what the objective with that is?
Of course. Well, hello, Heshe Mado. My name is Grace Fox, and I am a Tribal Healthcare Policy Analyst here at the University of Oklahoma's Native Nations Center for Tribal Policy Research. We are a policy institute here at the university, and we prioritize producing high-level research and policy analysis geared towards tribal leaders and tribal communities so that they feel empowered and educated to make the best decisions on behalf of their communities. And so this center has been around for a couple of years now. I just joined last June, so I'm coming up on a year working here at the center. The Purchased and Referred Care Report was my first major publication here at the university, and I am currently working on my second Sovereign Report, which should be done in June, so keep an eye out for that. But I work alongside Tana Fitzpatrick, who's the director of the center, as well as the associate vice president for tribal relations here at the whole university, Evelyn Castro-Cox, who's the research project manager, and Kwana Yazi, who is our office director. And I'm the fourth, so awesome. It's been amazing getting to work here so far and share about the center.
And I also gave you guys a link to the center's webpage, which they also have some other stuff on there that you might want to check out, like the Sovereign Cast. They have some podcasts on there and some roundtable type discussions and a YouTube channel and all that stuff. So there's a bunch to dive in there. But so check that out. Let's talk about the report, Purchased Referred Care and Cancer. So what was the catalyst for the creation of this report?
Exactly. That's a fantastic question. I joined here at the university as a tribal healthcare policy analyst through and under a National Institutes of Health grant called the ICON grant, which is Improving Cancer Outcomes in Native American Communities grant, to the university in collaboration with Stevenson Cancer Center. And so although I focus more generally on tribal healthcare as a whole, cancer is a big focus of the work that I do. And it was through these conversations with the ICON grant group and also just my independent research that I saw cancer as a huge problem for tribal communities, especially tribal communities here in Oklahoma. And there is such little research out there, not only just focused on tribal communities, but providing solutions that are geared towards tribal leaders and tribal communities, saying, what can we actually do about this health crisis? How can we help our citizens? And how can we help them, live their healthiest, happiest lives? And so my policy research really focused on purchased and referred care, which is a policy at the Indian Health Service that focuses on ensuring access to cancer care and other health care that cannot be provided at either Indian health clinics or tribally run clinics due to capacity or just lack of access. And so ensuring patients get continuous care, especially for cancer. And so just this kind of combination of, seeing this big problem in the data for tribal communities and also the lived experience that I have. This time last year, my mom was fighting breast cancer. And so I saw the lived experience of being a caretaker and also having someone I love being impacted by cancer and wondering, why isn't there more research out here about this? Why why aren't there people trying to, get the word out about this and make changes? And so I'm really honored and fortunate to be able to partake in some of the research and policy analysis that benefits tribal communities. And it's very fulfilling both personally and also professionally in this role.
Absolutely. So let's talk about the research, the material, the data that you collected to form the report. Could you kind of like in a nutshell give us an idea of where that data came from and what data it is?
Exactly. So as a policy institute here at the university, the Native Nation Center primarily pulls our data and our information just from what is publicly accessible, as we are focused and we write and produce our research geared towards tribal leaders and not towards academia or towards, other kind of recipients. And our focus is tribal leaders, tribal communities, and tribal partners, as well as just other people who are interested in our research. We really pull from publicly available information, and we don't oftentimes do independent academic kind of geared research in that way. But we do listen to tribal communities and say, what is the biggest problems? What do you see? Where are your constituents and where are your community members struggling to get care? And how can we best use our position as a policy institute at the university to advance policy research to meet these needs from, expressed to us by tribal leaders and tribal citizens. So it's been fantastic getting to find our voice and finding our process here at the Native Nation Center, and really excited to continue building on what we've already developed so far and continuing along that path going forward.
For sure. I want to remind you guys, if you have a question, pop it in the chat. We'll try to get it answered. So we've kind of gone over the data that you guys use. What did you find, if you can? I know I read the report myself, and it's kind of long. It has a lot of...
It is very long.
Well, it has great information in it. But can we synthesize it down into like, what problems did the report find? And then after we do that, we'll talk about what possible solutions there could be.
Exactly. Well, my report really goes on an overview of purchased and referred care, like I said already, which is an IHS program to ensure continual access for tribal citizens to healthcare that may not be delivered or accessible at IHS clinics or tribal clinics, but under the federal trust responsibility to provide care for Native American and tribal citizens here in the United States. Purchased and referred care was created to ensure continuous delivery of care. That is especially important when looking at cancer because Native Americans and Alaska Natives face higher cancer incident rates, higher mortality, later diagnoses, and just an overall heavier cancer burden. And that we can see in our communities today. Every person I talk to usually can bring up a lived experience and saying, well, my grandma had this, or my auntie had this, or my uncle passed away because of this, and they caught it too late. And the data shows and matches those experiences. And so, like I said, in my report, I provide all of the statistics, both nationally as well as Oklahoma centered in a section of the report. But I use this cancer data and this disparity to really focus on purchased and referred care as a policy and say, this is usually the pathway tribal citizens diagnosed with cancer need to go because unfortunately, many clinics, tribal clinics or IHS clinics don't have the capacity to provide cancer care like screening or diagnosis or chemo, radiation, surgery, and therefore those patients must be referred to non-tribal or non-IHS clinics or hospitals in cities or larger metropolis areas. And so looking at that pathway, I was able to identify a lot of barriers to access and or gaps that tribal citizens often run into when trying to receive that care. We can see that through transportation barriers, lack of access. Think about it. If you can't get to the hospital, you have to go multiple times a week for an infusion or radiotherapy, and you don't have a car or someone to drive you, that can be a big factor in dissuading people from wanting to go pursue that care. We're looking at financial barriers, insurance, and third-party coverage problems. We're looking at a hesitancy just because of historical mistrust in healthcare delivery systems. We're also looking at just barriers in knowledge and an understanding of what kind of policies out there and what kind of programs exist that could help me through this cancer diagnosis. And so looking at upping screening, looking at improving once diagnosed pathways to receiving care, and also follow-up and just general community knowledge and improving understanding, awareness, and comfortability in accessing care, knowing that it's out there. And I provide a couple of policy options for consideration for tribal leaders and tribal citizens later on in my report, which I can talk about a little bit later.
Yeah, let's just go ahead and jump into those policy recommendations.
Yeah, for sure. So kind of my first and foremost here in my report at the Native Nations Center is sovereignty-grounded, sovereignty-forward solutions, right? So we at the Native Nations Center aren't prescriptive. We are descriptive. So we want to provide neutral, nonpartisan, non-prescriptive information so that tribal leaders can make the best decisions on behalf of their own communities using their local context as their guiding star, right? But one of the first options we offer is self-governance, self-determination, and ISDEA compacts. So looking at actually taking authority of healthcare delivery programs and reorganizing them to fit the needs of their communities, especially if the cancer burden is high in your tribal community and you are a tribal leader. You can look at restructuring your healthcare system with a self-determination or self-governance compact to ensure that those needs are being met. Of course, that invites a bigger conversation about sovereignty as a whole and what that looks like as we move forward in self-governance and sovereignty focused initiatives, not just in healthcare, but in everything that we do as sovereign tribal nations. That kind of leads into my next option for consideration, which is regional, both intertribal and external partnerships. So looking at how can tribes partner with cancer centers or universities or other tribes to consolidate resources and materials to elevate access for their citizens and neighboring tribe citizens. I reference both, Alaska and some Pacific Northwest tribes who are working on really cool initiatives to kind of spearhead these projects. And I invite you to read the report and see those for yourselves. But that kind of also leads into service delivery models. I talked a little bit earlier about some barriers being transportation or living in rural areas or just not having access to these major cancer healthcare facilities. And so we can look at things like mobile units, screening vans. We can look at satellite clinics where hospitals put little clinics in more rural areas so there's less of a travel time. We also can look at teleoncology. That is a really cool technological advancement that we've found be elevated in the past years since COVID, right? An increase in being able to deliver some kinds of healthcare at home, permitting that there's internet and technological, access to devices. But those are some other options. I also look at care coordination, navigation, and education. So just educating the community and providing clear, accessible materials and trainings to tribal citizens about what the process would look like if they're diagnosed and giving them that information before they need it. So they already have a mental kind of idea of, okay, I feel prepared and I feel empowered to advocate for myself and my family members. And that leads into coverage and financial protections. It offers tribes opportunities to look at third-party coverage or insurance strategies, billing Medicare and Medicaid, in saving the purchase and referred care fund that is unfortunately small due to funding, lack of funding with IHS and with purchase and referred care specifically. And so looking at how to kind of conserve those financial resources and make them stretch longer for citizens who don't have other forms of insurance or citizens who have no other options than to use purchase and referred care. So I provide some kind of strategies that tribal communities and tribal leadership may employ in regards to stretching those resources. And that really leads into my last and final policy option for tribal consideration, which of course is sovereignty-driven federal engagement, looking at advocating for IHS funding levels and explaining what those impacts on purchase and referred care are. We look at discretionary versus mandatory appropriations for IHS as a whole and how that trickles down to the effects of purchase and referred care as a program. Addressing IHS workforce vacancies, right? there are extremely high vacancy rates at IHS clinics, and that impacts care delivery and then also access. If you can't see a doctor to get a referral, you won't be able to continue on the purchase and referred care process. And so that's usually an initial barrier to access. And then the last kind of three are purchase and referred care delivery areas, so PRCDAs, looking at expanding those boundaries, possibly advocating for the expansion of medical priority criteria and oncology pathways, prioritizing cancer as a priority in these medical pathways criteria, and then of course, alternate resource coordination. These kind of last three that I noted are specific, criteria required in the purchase and referred care handbook and process. To be eligible for that care, you need to meet these requirements, and expanding these rules or altering them to meet tribal priorities is another thing that tribal leadership could do to reflect their local definitions of success going forward. And so that is a whole bunch. I know that was a whole bunch of information that I just threw at you. And this report was meant to be 20 pages. It ended up being 49 just because there is so much information out there, and it's crucial, and it really is important to provide this, because where
Absolutely.
I had 6 months to do this research and write this report, tribal leadership doesn't have that luxury. And so being able to provide them this report, where yes, it does take a long time to read 49 pages, it is significantly less time than having to go into these systems and read the laws, read the policies, read the IHS manual and handbook, reading these lived experiences of people who are suffering from cancer diagnoses and then struggling in accessing care, and being able to consolidate that in one place for tribal leadership and partners is really important to me. And I'm incredibly grateful to have been able to think in this way and provide this report for the tribal citizens and tribal leadership who deserve it and need it most.
Absolutely. And I wanted to mention to you guys too, if you're an older citizen and you're like, what is purchased or referred care? You might remember it from the older name, which is contract health, because I know I think it was 2014. It's in the report. It talks about how that got changed to purchase referred care, because I'm dating myself, but that's how we always knew it was contract health.
Yep.
And being a journalist, I've often heard from citizens and worked on stories where they had a problem with contract health getting their care done, and cancer is one of the things that people have trouble sometimes getting treatment for that they absolutely need, could be life-threatening. So I do want to recommend that you guys check this report out, not only, even if you don't have anything to do with tribal government, because it's very important that just tribal citizens understand that there are some options, because, when you're stuck in the situation, you may go to your chief's office or your government and say, hey, I can't get this paid for, I can't work it out. It's hard for just a citizen to understand the issue. What's the holdup? What's the problem here? And this report provides you guys with some things to advocate for with your representation in the tribal government. You could go to your councilman or chief and say, hey, we need these types of programs to help alleviate this specific problem, because one of the things you point out in the report is that these problems are not something like genetics or predisposition to cancer. These are like environmental, economic, and geographic problems that can be solved if in a lot of instances, if there's funding that's applied correctly or more efficiently, right? So I wanted to thank you again for being on the program, Grace. I don't see any questions in the chat. Is there anything about the report or just generally this issue that we haven't talked about that you think is important to mention?
Of course. And I think you touched on, a bit of it, and thank you so much for reading it and taking the time to interview me today. It's been an absolute pleasure getting to write this report and do this research and pay it forward and pay it back to my tribal community and saying like, hey, look, I'm able to use my education and my background and my privilege to produce kind of research like this for the community. And it's been truly an honor. And I think that when looking at cancer and when looking at these policies, right, being informed, being educated, and being an advocate for yourself and your family and your tribal communities is what's going to last, not just for you, but for the 7 generations to come, for your elders, for your youth, making sure that people know what kind of systems that the federal government has a responsibility to deliver on, right? Healthcare,
Yes.
education, things like this. Make sure that you kind of are up to date and informed about these things, whether it be through my report or your own research. I think that's really important. And also, in talking about cancer, if you qualify, get screened, right? Check on your local guidelines and talk to your physician. I'm not a physician, I'm just a policy analyst, but talk to your physician about being screened for different kinds of cancers, especially if you have a genetic component or have environmental or lived factors that may increase your possibility of having cancer. We want you around. And I can speak, my life is for the better because of the people I've met in it. And if it means getting more people scanned for cancer, screened for cancer, treated, and then healed, I think that's really one of the best things we can do for our communities going forward for the long term. And so that's really what I have to share. If you guys are interested, I will be putting out another report in June, like I hinted at. It'll be more focused on tribal health and Indian health 101. So a much more kind of high level analysis of the policies and systems that have led us from pre-contact to today, what these healthcare systems look like, more of a general overview, but also with policy options for tribal consideration that you can think about when making governance decisions, or also just, like I said, be informed and be knowledgeable so that way you can advocate for yourself and your community. So keep a lookout for the research. We also produce other research here at the Native Nations Center, a lot on data sovereignty, AI, governance, legal stuff. It's super cool, and I cannot recommend enough that you reach out, check out our website, and keep up to date with us. And I'm super honored to be here, and a big mado to everyone listening, and then of course to you for hosting me today.
Absolutely, Mado. And you guys, they have a YouTube channel too. It's all on their website. You can go there and you could subscribe to their YouTube channel and catch their content, which I endorse. I did want to mention one thing in your one of the things you were talking there that occurred to me that we probably should have done at the start, but that's my fault, is, I get questions from non-natives a lot about why does the IHS exist? What's the point of that? Could you just, from your research, and it's in the report if you guys want to read it, if you're a non-native and you've made it to this deep into the interview, read the report. It explains it very well, but if you could give it to us in a nutshell, Grace.
Of course. So under treaty responsibilities, so treaties that the United States federal government made with tribal tribes 100 years ago during the treaty making process, one of the things that the federal government had in those treaties was to deliver health care to tribal citizens in exchange for their land and compliance. And we can see that being that continuity leading into today, right? So there were rations that were provided early on, and then, a couple of doctors, healthcare wasn't great early on. And I don't think, unfortunately, caring for tribal citizens was a priority at that point during genocide and assimilation. But as we moved to the 1950s, where tribal health was established in the Health and Human Service kind of department as Indian Health Service, we're able to see Indian health clinics, Indian health services be delivered to fulfill that federal trust responsibility to provide provide health care for tribal citizens. So that can look like having an IHS clinic near you and visiting that and getting health care. It can look like public health works and initiatives, and it can really look at other kind of grants and works within your tribal communities that promote healthy ways of life, whether it be focused on diabetes or mental health, addiction, substance abuse, or in this case, cancer, right? So that's a really kind of summarized version. And it all really comes back to the federal trust responsibility that they have to provide healthcare for tribal citizens. And that's really the law and policy that I ground my research in, is looking at these and using those to say, look, we need this, and we're owed this.
Yes, absolutely. I couldn't have said it better. And one of the things that we saw, guys, with the McGirt decision is that treaties are the law of the land. They are above everything, So that's where that stuff is established, is in treaties the tribes signed with the federal government. So with that, I think it's a good place for us to close. I don't see any questions in here. Abalove says very true. I don't know what Abba's referring to there because it was a while ago, but thanks for tuning in, guys. Grace, again, thanks for joining us. And anything that you guys produce in the future, you want to come back on the program, come right back on. I'll be in touch with you, and we'll talk about it and get the word out because you guys are doing great work there.
Oh, thank you so much. That means the world to us, and we cannot wait to share all of the other amazing things that we produce, and would love to be back on the podcast and the live stream. So thank you so much. Big Mado to everyone watching, and yeah.
All right. Well, Mado, guys, we'll see you later. Hadum. Chihichat, Lees.